Lusk. I'm a licensed clinical social worker with the Hawai'i Health and Harm Reduction Center. We're a statewide program, though our footprint on the Big Island is relatively small, just have one staff there. But so grateful to be with you all today. And also my partner in Justice, Dan, just give him a chance to introduce himself.
Hi, everyone. You know me. I've been annoying you all for years about some of these issues, and I am grateful to be here today and so grateful to Going Home Hawaii for sponsoring this, for bringing everyone together. It's your goodwill that actually made this a possibility. And all of you who showed up and who responded to our emails and who came to have conversations with us, all of this is your work here. And so I just wanted to express my gratitude for that. I work at a nonprofit called Community Oriented Correctional Health Services. We started in 2005 with a grant from the Robert Wood Johnson Foundation in order to try and improve coordination between community health systems and correctional health systems. In this process, we have been working on policy issues from the federal level all the way down to the state level. But some of you also may know me from my time when I was working at the Legal Aid Society of Hawaii and working at the Hawaii Island Community Health Center, where we started a medical legal partnership there. This work, working on some of these issues around Medicaid that we'll talk about later on, is what took me away from you all, but it's also what's bringing me back to you today. So I'm just grateful again to continue to share what we're learning along with you. So back to you, Heather.
Thank you. And as Dan gets us to the agenda, we are so blessed to have Dan and his expertise. When Dan and I were checking in yesterday to prepare for today, I think we realized it's been 10 years that Dan's been dedicated to changing the system and particularly to support getting folks why they are still incarcerated onto Medicaid. And as many of you know, we had a recent celebration because the Hawaii waiver has passed. I'll let Dan talk more about that. But more than ever, this sequential intercept model, this mapping exercise that you all did and that Going Home Hawaii prioritized is going to make you perfectly aligned to be able to help implement that waiver as well as other changes coming. So our agenda today, and there's Dan and I being very happy with Les. And again, Les, you and your team did a fantastic job. And in fact, in all full disclosure, even though Dan helped me to do the one on Oahu, I think we both love the one on the Big Island even better. Don't tell any of our Oahu folks I said that. But that's how much we appreciate it and how I think how cohesive the connection of all of the community members were. So Dan and I are going to do a brief overview of the SIM sequential intercept model, the mapping process, what the process was on Hawaii Island in both Kona and in Hilo. Again, Dan said it, you all are the experts, and a lot of what Dan and I did was just facilitate your mana'o and your content to put it together. And so then we're going to go through the intercepts from 0 to 5, talk about the key findings. There were some really clear themes between even I think aligned with the two with Kona and Hilo, but also some differences. And then we're going to really zero in on some of the policy stuff, which I'm so grateful that Dan is the expert in policy that he is, because we're really lucky to have that kind of expertise as we get ready to implement our waiver. Next slide.
Just want to say, go ahead.
Oh.
I'm sorry. I just want to say I didn't realize how gigantic I am until I'm in a picture like this. So,
Yes, but so many of you already know what SIM mapping is, but just to get us on the same page, the sequential intercept model was developed by SAMHSA, the Substance Abuse and Mental Health Services Administration, to identify kind of exits, for lack of a better term, exits from the criminal legal system for people that their true challenges are behavioral health, substance use, and mental health. And how do we look with a magnifying glass at pre-crisis? Crisis, that's intercept 0. 1, when crisis is hitting law enforcement, and now we have 988. Moving along, then if that turns into an initial detention or court appearance, getting into our specialty courts and incarceration, then looking at when people come back from incarceration into community, and then how do we in the community support people to hopefully stay there and meet their goals, as well as be healthy and happy. So I know this sounds very idealistic, but this opportunity gave you all in Hilo and Kona an opportunity to say, well, what is already happening in each of these intercepts and what's missing? The other big piece it said is who are the players and the stakeholders? We're going to talk a bit about Luckily, majority of the key stakeholders were in the meetings, but Dan did have to do some follow-up interviews, and there may still be some gaps that we are continuing. This is a living document, right, Dan? That this is a snapshot in time of the gaps as of late 2024, early 2025, but already things have changed with the waiver passing, and there may be new services coming online. So this is going to provide a great foundation, but also, again, a living document to identify where's new things coming online, where's opportunities, and then what are the priorities of this consortium going home Hawaii to advocate for, especially as we tomorrow start our legislative session. And then I guess the last piece, which is not to be under emphasized, is the relationship building. I'm not sure how many of you, if you could maybe raise your virtual hand, how many of you participated? I think quite a few of you. And hopefully you also met other folks working along this continuum of care. And so it's also an opportunity to hopefully bring more people into the Going Home Hawaii Consortium, continue to build these relationships with all of the sectors, and again, move forward on the gaps and the opportunities to make Hawaii Island, hopefully, an opportunity to get more people out of the criminal legal system into the services they need, and ultimately actually even go upstream to avoid crises. So that, in a nutshell, is the sequential intercept model. Depending on who you talk to at SAMHSA, they recommend every 3 to 5 years, at least from my little view with crisis intervention team. And next slide, I think, is a great quote by Dr. Michael Champion, who I don't know if he's here, but participated in Hilo and Kona and in Oahu. And as he says, we need to know where the action points are so that we can improve across the board with all the services. So again, the goal was to create a map, which you'll get to see a bit about, as well as identify, again, where the resources are, where the gaps are, and where are the opportunities for us to fill in those gaps with priorities. So on that, I'm going to turn it over to Dan to talk about the goals and the process of this. And Dan, I probably forgot something that also you could highlight around our overview, and I'll be back in a little bit to talk about what we learned in the intercepts.
No, I think that that's great. Thank you, Heather. Um, so how did this all happen? The process, just want to talk through because again, want to reiterate what Heather said is that this was what we were doing is we were just coming in basically cheating from all of you. We were getting you all in the room and then listening to the ways in which you've seen the system operate right in front of you, and then tried to take that information and then feed it back into a report for you all that could be a foundation for what sorts of priorities you want to focus on in the future, but also to just be prepared for what can happen with these new waivers that were just approved last week, and even some other federal policy changes that we're going to talk about in a moment. They're very exciting. I'm very excited about them. I'm probably like one of 7 people in the entire country who's like excited about it. So I'm trying to get more people excited about it. But this is just sort of my nerdy lot in life, is to like look at these little statutory things that change and then think about what can flow out of that. And you all have a wonderful foundation for being able to maximize what flows out of these changes. So, the process for this was that we had meetings. We had 2 meetings, one on the Kona side and one on the Hilo side. And what we wanted to do was we wanted to be able to bring people together who were working on each of those sides of the island and try and talk about what are the resources that we have, what are the gaps that we've seen inside of this system, because we know that it it already is we're really underselling the differences across Hawaii Island by just having it broken down into Kona and Hilo. There are so many more differences if you were, say, down in Ka'u of how that justice system operates. But we wanted to be able to capture this information when we could. So we had an all-day meeting on the Kona side, and then we all hauled over to the other side to Hilo. Got to experience sun and then rain, 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 rain the next day on the other side. And then we took both of those meetings and then turned it into the report that we'll be talking about shortly. So what happened is we brought together folks from the health systems, the justice systems, and the social service systems to come and talk about what they're seeing every single day. And we did this through a facilitated discussion. It was Heather and me up there trying to listen to you all and try and move things along, trying to also make sure that we dug deeper onto things that seemed of interest to people in the room. And then we took that information and we analyzed what that looked like for each side, and then pulled out distinctions between the Kona side and the Hilo side in order to try and describe what was different on both sides of the island. And from that, we identified the strengths of each side. We identified the strengths at each intercept. We pulled out the different gaps that people mentioned there. And then we also highlighted some of the opportunities, especially as we were looking towards these policy changes that ended up happening, thank goodness, in the 11th hour here. So again, I'm going to keep on saying this. This is a community collaborative event. So it really required us to bring together people from diverse sets of stakeholders. So of course we had Going Home Hawaii and HHHRC, HRRC, being the people there on the island who were who were the main sponsors of this. And then you brought in me from coaches to be able to help facilitate the conversation and bring in a different sort of a different lens from looking at this from a federal point of view as well, from my experience of bouncing around in different jurisdictions across the country. So we had folks from law enforcement there, healthcare providers, we had peer mentors, we had people from housing, and that's just like a very small part of the list. We had probation there, we had jail health providers there. And of course, we had the people who are doing the work in the community, just providing health services year round, even when they're not connected with the justice system that they were there. So we, in this conversation, started to address some of the geographic disparities. And just to highlight some of those, we learned very quickly that there are some diversion challenges in Hilo already. We've got one really great dedicated staff member who is doing all of the AMHD diversion in Hilo. Over in the Kona side, we just don't have anyone at all who's stationed to do that. So Kona doesn't have any diversion programs that are operating through AMHD there. We also were able to talk about just some of the workforce challenges. Hilo, as we know, has a lot more access to resources, and Kona has a lot of staffing shortages. And also the housing costs on the Kona side and the Hilo side are really challenging, but on the Kona side, it's especially challenging. And so, of course, access to housing creates a lot of challenges with being able to bring in workforce in order to provide the services for folks, or even to be able to find places for people to live as they're leaving incarceration, or because they have untreated or they're in treatment for substance use or mental health needs. So these are just some of the distinctions. But I want to also say one thing. Today, what our job is to just get you like a little excited to dive into the nerdy work of reading a 28-page report that Heather and I put together. We are not going to be covering absolutely everything that's inside of this document, and you will be grateful for that, I'm sure, by the end of this abbreviated conversation that we'll have. But what I do really hope that you'll do is that you will pick up that 28-page document, try to make it nice and easy to read. My hope is that it is not something that is very painful, but just to look through it too and to read and see how we have pulled out some of the distinctions between Hilo and Kona throughout the document. So please read it. It is in the email, the invitation email that came out today to this conversation. So I really hope that you'll actually take some time and go through the document. It also has a really great appendix, which describes how the 704 process works and how some of the release programs work on Hawaii Island. So it can really be informative too, to help you understand how people are moved through this system, and really honestly, how challenging it can be for an individual who's going through this system to access care. So also as a part of this conversation, we were able to identify some like pretty important priorities. Obviously, housing is massive in this, but also just some of the mental health services that are really necessary. Like, for example, we don't have every level of the ASAM criteria. So the ASAM criteria is the American Society of Addiction Medicine. What that is that's a framework that allows you to be able uh, um, to understand what someone's needs are. You can use a tool from them in order to understand what someone's diagnostic levels are, what actually diagnosis that they have, and then be able to appropriately put them in the right setting, whether that be for just some simple outpatient care that someone might have, or some sort of clinical support that they might need, or some sort of therapeutic intervention, just really basic stuff, all the way up to intensive residential treatment. We don't have all of those options on island, which means for people who are the sickest or most in need, they're going to have to go off island for some of those services. And if they can't go off island, it means that those needs are just not going to be met. So identifying those things was a really important part of this process as well. So, I just want to highlight that all of our work together, and I don't have to tell you all at Going Home Hawaii this because this is like the ethos of what we do every single month here together. But we're working together to try and develop a shared vision. And we're always listening to the people with lived experience. We had so many people with lived experience show up. I mean, they already work for some of the agencies that we're working with, which is amazing. But they also showed up and shared what their actual experiences were like when they were arrested, or the people that they're working with who are still incarcerated at HCCC, what they're experiencing. So that's absolutely important. And at that same meeting, we had administrators of the systems and the users of these systems, whether they're incarcerated or not. So this was a community effort. So even though Heather and I don't even think our names are on the front of it, which is perfect because this was all of your work in order to actually make this happen. So just want to highlight some key themes, of course, that showed up, right? These are the things that are not going to be a surprise to any of you. That picture there is from our day over in Hilo. But we obviously we didn't uncover this. Like this is obvious. There's a critical need for housing on both sides of the island, and housing for people who are not incredibly wealthy, for people who are just living, people, and that includes people who are working, right? So the lack of housing for people who are working inside of these systems is a major challenge, and that means that we end up with workforce shortages. So if we can't have places for people to live, we can't have places. It makes it impossible to give jobs to people who are interested in working inside of these systems. We also talked a lot about coordination and data sharing challenges. So, as people are moving from community systems into the correctional systems, the data does not flow into the jails. And likewise, when someone's being released, that information doesn't flow back out into the community. So what happens in those cases is we create some discontinuities of care. So as many of you would, I think, would be shocked if you were to be discharged from a hospital after receiving care there and you didn't have a discharge plan in hand to understand what you were supposed to do next and how you were supposed to be able to follow up on your care. But unfortunately, as people are leaving corrections, we don't have something like a discharge plan that helps them be able to understand where they're supposed to go next and who they can reach out to if they need help. Now, Going Home Hawaii has put together the RAP cards for people as they're leaving incarceration. But, there's something a little bit more that we need than that in order to try and help people understand what's going on. Like, how do we bring in the providers into this system so that when someone is leaving incarceration, how does someone like Hawaii Island Community Health Center know, oh, this person who hasn't shown up for the last month or two isn't here because they were incarcerated. And while they're incarcerated, this is what care they were given. This is what prescription they were given. And those sorts of things just create discontinuities that make it more challenging to help support people and help them avoid reincarceration. And of course, one of the big and important things that we learned here as well is that there is a need for increased diversion opportunities. We have a framework for a post-charge diversion program. So one would be charged by a prosecutor, and then they would be able to then go through a diversion program. There is no pre-charge diversion program. So any moment that you're diverted, or often those are called deflection programs too. There's also a need for deflection opportunities, which is before you even get into this system or get taken to cell block, how can somebody be shuffled off to a more appropriate community setting? So these sorts of things, besides the fact that the post-charge diversion opportunity doesn't exist on the Kona side, there's a need to even expand that broader and to really, and this is where the sim is really powerful, is it shows us opportunities in the folks that we can lean on in order to try and build out some of those pre-trial or pre-charge diversion, deflection opportunities. But first, we required actually looking at what the needs were on the island in order to get a good sense of this. So with all of that, this is what the Hawaii Island sequential intercept model from data taken in August 2024 looks like. So I just want to walk through really quickly what it looks like here. So intercept 0, you'll notice first and foremost, is not on here, right? Because if we did include intercept 0, it would be far too big and it wouldn't actually be all that informative. But intercept 0, you can think of as sort of the background. What is already going on inside of the county for people who have health needs generally, who are not necessarily involved with the justice system at all? What is just kind of our safety network that exists? And I call it the background, right? Because with any background, you can point out and identify components of the background to pull to the front in order to become the foreground. And so this background, I think, exists across every one of the intercepts, which is why I like the term intercept zero. It isn't really something that precedes intercept one, but it's something that we can think of as a resource bank that we can try and pull resources from along all of these intercepts in order to try and help support. So, you know, you can spend more time with this inside of the actual report as well. But just to highlight, we have non-emergency numbers now. 988 did not exist 3 years ago, 4 years ago. It's very recent. And so 988 is able to deploy sort of a crisis mobile outreach. So 911 does not necessarily need to be the only number that we reach out to. Of course, 988 has some limitations. It's very new. If you're calling from a non-808 number, it's going to shuffle you off to some other jurisdiction, and then actually getting access to the person, getting back into the jurisdiction is challenging. But 988 is able to mobilize crisis mobile outreach in order to be able to respond to a need, and then crisis mobile outreach can turn into some case management services. One of the other things that I failed to mention too, I'm sorry, when we were talking about the need for coordination of care, is that sometimes people who are moving through these systems can have a lot of case managers. So many case managers, in fact, that it ends up becoming impossible to meet all of the different things that the case managers are setting up for you. And so, one of the things that as a part of that we can pull out of the SIM is that there also is a need to try and streamline how someone receives case management services and who is responsible for the case management of that individual. But if 988 isn't able to get people the right resources, we have 911, which can, of course, dispatch a fire or police response. The police on Hawaii Island, as Heather is going to talk about, has really great coverage of CIT officers. For people who are having a mental health crisis, those police officers can go through what's called the MH1, or now the Mental Health Emergency Worker process, which reaches out to an individual on Oahu and then is able to get authorization to take an individual to Hilo Medical Center or Kona Community Hospital or North Hawaii Community Hospital, depending on where that individual is. Eventually, the police will take someone to cell block, which is not the jail yet, but it is under the jurisdiction of the Hawaii Police Department, and that's where the Hawaii Intake Services Center will come and do the pretrial assessment to understand the risks of someone who's involved with the justice system, and to also provide a pretrial and a bail report for the judiciary to understand whether or not or how bail should be set for someone. At this point, AMHD diversion in Hilo is able to intervene and offer diversion services, and also things move into the pretrial hearing where it can be determined whether or not someone is supposed to be really receiving supervised release, unsupervised release, or else whether or not they're not supposed to be released at all and then are taken to HCCC. So the courts, we do have different court options for people. It isn't just a one size fits all, but the problem is that there haven't been a lot of on the Kona side, there haven't been a lot of referrals to the juvenile or veteran treatments court. So essentially those are only operating on the Hilo side. There is a drug court program as well on the Big Island Drug Court, of course. But that is should point out that that is a probation court. So for someone who's at risk of revocation of their probation, those are the folks who can then who can utilize the drug court. So an individual leaving drug court could be seen as not guilty. They could be sentenced to probation. They could be sentenced to HCCC, which for a sentence less than a year, or else they can be sent to another DCR facility, a facility that would hold someone for longer than a year. And that could also include off-island sites too, like Saguaro in Arizona. From whatever that disposition is there are reentry programs that happen. Those are mostly focused more on people who are leaving the longer term stay, the DCR facilities, where you can get MedQuest reactivated, receive ID services. You can receive gate funds, which is a little money in the pocket in order to be able to help support you as you're leaving, and then also work furlough programs. There is no specialized mental health reentry, especially from the jail side of things. The jail just because of the way people are moving in and out very quickly, there's not a lot of reentry services that can be offered in that short amount of time. As we'll talk about coming up, there is now new opportunities because of this Medicaid 1115 waiver that could fundamentally change the way that those reentry services are offered. So it'll be really interesting to see how those develop. Then, of course, leaving from reentry, there are probation or parole options too, where, of course, parole and probation officers will try and engage with community systems too, a lot of those Intercept Zero services. But there are, of course, major challenges with just connecting people to services as well. So with all of that, we're going to start diving in, and I'm going to put more people here, so I'm just not talking to a blank screen, which happens when I'm doing a PowerPoint too much. At Intercept Zero, just again, want to highlight that this is the types of things that you all are so familiar with because you all are working in Intercept Zero. So Intercept Zero is the place where you can have early intervention, where you can identify and support people so they don't have to get involved with the justice system to begin with. And so this is, Intercept Zero, you could even be thinking of 988 as also an Intercept Zero service as well. But besides that, there is all of you who are doing such great work. So the Hawaii Island Community Health Center offers really broad sets of services, primary care. They offer peer support, community health workers for people, offer medical, dental, behavioral health. They do street outreach with community health workers. I'm looking at my notes here too, because there's just so much I couldn't possibly remember it all. But they are really the main primary care folks on the island. And, as Hawaii Island Community Health Center has come into existence through Bay Clinic and West Hawaii Community Health Center merging together, it really covers a majority of the lives on Hawaii Island. But besides Hawaii Island Community Health Center and all of their outreach work, Hope Services they're the ones who are out there doing so much of the work with the unhoused population. They have emergency shelters. They have a wider range of services for families. They do housing focused outreach for unhoused populations. They also are community integrated service providers. So they already are MedQuest providers trying to house people and receive Medicaid dollars for that. They also do work around assisted community treatment. So this is a program that allows for um, mental health and substance use care through the judicial system. And these are usually people who might not be able to seek care on their own. So they'll help a petitioner through the process of getting court-ordered treatment for an individual. And that support is something that can help somebody show up when they might be more challenging for them because their illness is keeping them from being able to receive support. They also do assertive outreach as well, and they assist Ohana health plans, community care services, which we will talk about in a bit, as well as one of the major challenges and gaps. But anyway, they do so much there on the island as well that probably, Hawaii Island Community Health Center, Hope Services, and Going Home Hawaii are the ones who are like obviously the rock stars inside of this area as well. And Kumakahi Health and Wellness too, of course, in this process. So Going Home Hawaii, as we know, we're all a part of this consortium. They do housing work. They have the High Fuse program in order to try and get a more structured approach to understanding what people need. They do wraparound supports. They have 9-month window of hope. They have the J League. They're just out there doing really incredible work inside of Intercept Zero. And of course, HHRC, Hawaii Health and Harm Reduction, is operating syringe exchange there through Kumakahi Health and Wellness. And then we also have a broad range of substance use providers. But as I mentioned, not every one of the ASAM criteria levels of care that are necessary through ASAM. So for other providers we have on island, we have Kualoha Olamau. That they offer methadone, but they don't offer methadone on the Kona side. So that means that there's a lot of travel that has to happen for people who are receiving methadone on the Kona side. Lokahi treatment centers, BISAC, but on all of these, there are limitations that exist inside on the Kona side. Hilo has a lot more range of services and service providers than the Kona side, and so that creates a lot of challenges. So on the Kona side, there is not really a lot of detox and and there are no methadone services. And although 988 is a really incredible and promising practice and is being created, it's a great foundation, but there are delays when it comes to crisis response with 988. And we had people who were sharing stories of the challenges whenever they'd call 988. So although 988 is getting up and running, we should really view it as a foundation with a lot of opportunity to grow, which is really exciting. Also, on the Kona side, or on Intercept Zero, we still have a lot of fragmented systems. So I'm glad we have people from Unite Us here, and they showed up for the sequential intercept model meetings too. But really, in that process too, they were able to share with us that it can be challenging to get providers to buy in and to use their closed loop referral system, even though it's free for nonprofit providers, which makes it really challenging to try and break down some of these silos because it's a really great tool for trying to break some of that down. I also just want to highlight that people mentioned in Intercept Zero who were interested in reaching into HCCC in order to provide care. But of course, post-COVID, there have been some real challenges with trying to improve that in reach. And I think that we'll see as we're responding to what the waiver is going to require, that hopefully it'll be easier to do some more in reach inside of those inside of the jail. With that, I'm going to hand it over to Heather for Intercept 1. And Intercept 0 was the biggest, and that took the biggest, most amount of time during the day. So I'm glad you all survived that with me.
Yeah, thank you so much, Dan. So it's interesting when looking at the sequential intercept model that was done, that Dan helped facilitate, and it was done on the Hawaii island. Previous to this one, to me, this is where we saw the most changes compared to where we were in the beginning and where we are now with the advent of 988 and CIT, which both of Dan mentioned before. So again, intercept 1 is when somebody's already in a crisis. And then what do we do? And as you know, there's not a lot of options. As you see here, there's a brand new behavioral health crisis center in Hilo that just opened, but there's not one in Kona. And before that one in Hilo, there was really no place to take folks but the hospitals. But at the same time, what we've seen, as you see here, is a development of 988 in addition to the crisis mobile outreach. So we had Care Hawaii actively participate since they run the crisis mobile outreach and the 988, as well as I believe we also had a little bit of parents and children together who are focusing on crisis and those under 18. There was quite a bit. The island is huge, so not a surprise that there is a delay in response times, not just from crisis response, but with 911 as well. And right now, it's really one or the other, meaning that you can call 988 and see if there was a lot of discussion about the verifying, for example, right, Dan, of the person in crisis and needing to have that person there to verbally talk about what's going on with them. And then, of course, if it's a significant crisis that has a imminent harm, they could, as you see with the dotted line, bring 911 in. And so I think that we're going to continue. This is one area that will continue to grow as the staff shortages came up a lot, not just with Care Hawaii, but with almost every, I think, entity that was participating. I know that's true for most of us across the islands. And so when fully staffed, what does this look like is another question as far as response times. And again, hopefully having the crisis continuum addressed so that we don't need to involve 911. So the other big piece that's changed since the last sequential intercept model is been CIT, a crisis intervention team. And I was really blessed actually, since I'm the clinical lead for Honolulu CIT, I see Kathy on here from NAMI and a few other folks. The Honolulu CIT helped start the Big Island CIT, one training in Kona and one in Hilo a couple years ago. And now the CIT team is all on Big Island. And I will say that the Hawaii Police Department has more percentage of crisis intervention team trained officers than any other police department. As you see, there's 77. And Kathy, I actually think you had a training since we did this. So it would be good to get the updated numbers. I think they had another training at the end of last year. As a quick primer, crisis intervention team is a 40-hour best practice curriculum that's done actually around the world. The one that the Hawaii Island uses, the best practices curriculum from a CIT International, and it's to train police officers in mental health, substance use, suicide, homelessness, all of the other issues that they may come in contact with, and then a couple of days of de-escalation so that police officers have more skills to be able to de-escalate and hopefully not have the interaction result in an arrest, a detainment, or any kind of harm. And then the police officers can then, lastly, if they see the person is in crisis, whether it's CIT or another officer, the other intervention that didn't exist even when CIT started was the mental health emergency worker. I believe that Dan went over that, but briefly, it's a psychologist or other certified behavioral health person. It's actually through Queens here on Oahu. The Hawaii Police Department officers call, have that person, that behavioral health expert, assess. And if they believe that the person's at imminent harm, danger to themselves or others, or doesn't have competency, then they can tell the police officer that, yes, you can take this person to either the Behavioral Health Crisis Center or Kona Hospital or Hilo Hospital or Hilo Medical Center. So this is another way that instead of arresting somebody in crisis, we can get somebody to the care they need within the medical setting. And again, oh, I'm sorry, and North Hawaii Community Hospital. So as my understanding is that the behavioral health crisis centers, there's now 2 in the state, one in Hilo, one in Oahu. They do want one for Kona. They want one on every island, that this is actually going to be a better place to take people in crisis, or where people can self show up in crisis. Because again, I think we all agree that when someone's in the midst of a mental health or substance use crisis, having them be incarcerated is going to facilitate more trauma and more crises instead of helping get them the care that they need, which is often more of a health related issue. So this is, I think, what for me, an area that has not only had growth, but has a lot of potential to decrease response times, and get more places for people in crisis to go than the hospital or arrest. Turn it back over to you, Dan. I think I highlighted most pieces, but you're going to bring us through what happens if somebody is detained, and what goes on from there. Thanks, Dan.
There we go. I couldn't get my little microphone thing to show up. I was like I don't know any hand signals to let anyone know. So if that happens again in the future, just let you to know my computer's running slowly. One thing I wanted to highlight too, we talked about lack of non-emergency transport was like a major challenge because, HPD's, what they said is if there's some place we can take people, we're interested to take it. But the lack of non-emergency transport is a real challenge. Happy to report in the recent waiver that just came out, there's a component of it that does touch on non-emergency transport. I don't know what the full contours of that are yet, sort of outside of my area of immediate expertise, but it's something that I'm going to be looking into, and just a really interesting thing to highlight that has also changed since our last conversation. So Intercept 2 is really where the intake service center shined. I mean, it was really wonderful to have Jill there and talking about waking up. Basically, she gets up before the sun, and then she helps the sun get up, and then she goes to work every single day to go in and try and understand what the needs of people are as they're being held in cell block. So, just to reiterate, people who are arrested are taken in cell block. Cell block is where the intake service center is able to do their pretrial assessment. And that assessment then helps inform the bail report and helps understand what are the different options for people to move out of this setting. Uh, you know, like I said, ISC is doing a lot of work, not just in the cell block, but also as people are entering into HCCC as well. But that is a really challenging job, and it can be incredibly crowded for people, especially after a 3-day weekend. Intake Service Center has a lot of people that they have to go through and understand what their needs are, and then provide that report on the other side. Uh, so they just like deserve a lot of credit for what they do. They use the RS pretrial assessment tool. That tool will help provide the assessment for what bail can look like. But I do want to note that it isn't sort of a clinical decision-making tool. Some jurisdictions across the country are moving towards a more clinical approach to understand what people's needs are, in addition to the obviously the understanding of what people's risks are for fleeing the state. And so those sorts of assessments can be really useful, not just for understanding what someone's needs are, but also for helping the jail, as someone has moved into there, to have a better understanding of what someone is coming into the jail with and what their needs are. So, obviously, like beat this drum a few times already, but there's just really limited pretrial diversion services in Hilo. Those are all post-charge. And then on the Kona side, there's just no diversion programs at all that are up and running. And that's really a workforce challenge. Part of it's a workforce challenge, and part of it's just that there aren't the structures yet for it. There is not really a deflection system. There isn't a pre-charge diversion program at all. So that is one of the major challenges that we face, because if we don't have pre-charge diversion, we don't have deflection. What that means is we're forcing everyone further down the funnel. And the more that we force people further down the funnel, the more we have overcrowding in cell block, the more we have overcrowding in HCCC, which just compounds all of the other challenges that exist inside of these facilities. So by creating more pre-charge diversion options, by being able to create deflection opportunities, those sorts of things are going to really lessen the burden on further downstream activities as well, and really fundamentally change what we need out of HCCC as well. One really, really important thing to highlight that I'm hoping that the Health and Wellness Committee will work on, and since I'm on that committee, I'll probably continue to be annoying about this and remind us from time to time, is that people who are arrested are getting disenrolled from the mental health case management called CCS, which is a specialty case management service for people who have a higher level of acuity. So these are some of the people who have the highest level of mental health needs. And the moment that they're arrested, they're being kicked off that plan. So there is no, as far as we know, we haven't seen it anywhere. And Dr. Champion was there at the meeting too and said that he doesn't see any reason why this was supposed to happen. But people are being disenrolled from this program if they're arrested. They're not charged with anything yet. They're just arrested. They're not convicted of anything yet. They're just arrested. So what happens when an individual is arrested and then say released later, taken a cell block and released, no charges ever against them? Well, they've just lost access to all of their specialty mental health services that are important and also are connected to their housing as well. So this is a really, really major challenge and something that we just want to make sure that we're highlighting and that we're keeping in our sights as we're thinking about how MedQuest is going to be more integrated into these systems. And so, of course, wanted to take a moment to shout out the restorative justice program and how that's operating. And I know that I know that there's always hope that that will be able to be expanded further too. But that's just a really great and exciting opportunity because look, our justice systems are not built, and this is across the country wide. They don't do a great job of necessarily helping people come back into society in a way that is healing both for them and for the people that have wronged. So these restorative justice programs are important, not just for the people who are moving through the justice system, but also the people who often feel like they're just equally being as alienated as the people who are being charged with the crime, but the people who are the victims of the crimes as well. So just wanted to shout out that as well, and to say that that's a really exciting and promising practice too. Is this me again, Heather? I'm sorry.
Nope,
I
it's me. Yeah,
okay,
nope,
perfect.
I
You want to make
think it's
sure.
me.
Yeah,
Yeah, thank you.
great.
And Les, I'm just trying to be mindful of time. I thought you wanted us done by 12:30. Do we have a little bit of grace with you, time-wise?
Actually, schedule till 12:45 or so, so we can leave some time for questions. It
Okay,
goes till
sounds
1 though, so you have lots
okay.
of time.
Okay, great. Thank you. So you heard Dan when he was looking at the entire intercept mapping about some of the specialty courts only being in Hilo. So this is again is an area that could have more diversification of some of the specialty courts, especially there's been whether it's drug court, veterans court, some of the other specialty courts that have been proven to be really effective, especially with the peer component. But I think a lot of what came out of here, Dan's already talked about, has been the disconnect in how do we support our folks when they are interfacing with whether it's in the courts or the correctional systems with their health and well-being. Many of you know about the challenge of some of our aging facilities and the overcrowding at HCCC, as well as being able to support people again with their medical conditions as Dan said, we now are going to be able to hopefully work with our colleagues at DCR, we know some of you are here, around the 90-day, and that kind of gets into the next intercept that Dan will talk about, but getting folks onto Medicaid or getting it unsuspended, hopefully 90 days before release. And that should hopefully really support a lot of this coordination. One of the things we really want to highlight as a best practice and really uplift HCCC and DCR has been the expansion of Medicaid-assisted treatment, or what I call medication for opioid use disorder, or MOUD, that is now available for people to be inducted while they are in HCCC, and then do a warm handoff to community partners. I believe one of the major partners is BISAC, who participated in the mapping. But this is exactly the kind of collaboration that we want to highlight and uplift, where it's clinically appropriate for folks to get medication for opioid use disorder or MAT. We also know that that means that folks may be less likely to use other substances when they're released, and then being able to do a warm handoff to a provider in the community to continue. And I'm really happy to share that H3RC is one of those providers. We now have clients on all islands, some of them on Hawaii Island, even though they're seeing a practitioner here in Honolulu. So more and more, as the health committee for you all, as well as the health committee and the coalition on Oahu, can really work with our colleagues at DCR, because we're working with the same people, and how do we maximize the waiver, as well as some of these other best practices to do warm handoffs. So I'm going to give it back to Dan to talk about how important the reentry process is in that warm handoff, so that information and coordination goes with folks as they come back into community.
Great. So Intercept 4 is reentry, which, reentry should, best practices for reentry is it starts the moment that someone is even booked into a jail, or I guess into a cell block here in Hawaii. So reentry is absolutely important to try and make sure that people are able to transition out of the justice system and into the community in a way that isn't going to wind up having them end up back inside of jail again. So this is really the process of just coordinating with people as they're leaving jail and prison. This is going to be the biggest area of growth. We're talking about the waiver coming up here, but what this means is that reentry could now be supported, or will be able to be supported through MedQuest dollars. So to be able to provide certain services to people 90 days before leaving. And as many of us know, people are incarcerated generally can be incarcerated. Vast majority of people who are moving into HCCC are going to be there for fewer than 90 days. So that's a really important opportunity for beefing up what happens in reentry. So some of the stuff that does happen, I just want to again highlight that a lot of this is more coming from the side of the people who have been sentenced to a year or longer. Those are the people that you have a little bit more time to be able to work with them. And the real challenge is people who are moving in and out of the jail. That also happens to be the people who are probably most in need of some sort of mental health or substance use disorder treatment programming. So at reentry, the DCR works with navigators to reactivate Medicaid. Medicaid is supposed to be suspended when somebody enters into the jail or enters into a correctional facility. And then as they're leaving, it's supposed to be reactivated so that they can then go and see a provider right on the other side without bumping into any challenges. That is, just from working with my friends at the Hawaii Island Community Health Center, that can be a slow process. Sometimes it can be really challenging. And so it'll be really interesting to see what this looks like now that Medicaid can be reactivated even 90 days before release, because you have to have your active MedQuest benefits card on in order to be able to receive the services. But of course, with reentry, we know the challenges are that there's not a lot of places for people to go. This is there's an absolute need to try and make sure that we can provide services to folks, housing services to people, so they have a place to go, because that's the foundation for them to be able to get their lives together. It's going to be really challenging to get work or to be able to take care of whatever untreated and new mental health conditions that are just being discovered because they have access to health care. Without housing, it's going to be really challenging to maintain whatever's necessary to make them healthy. But also, identification. I know that this is something that's required by statute, and that the reentry folks have been doing a great job at DCR to try and create some policies around that and to get things up and running. But we did hear from folks that it is delayed. And of course, for my time working at the Legal Aid Society, so many people are really unable to get to the next step in their lives because they just don't have IDs, particularly for unhoused people too, because they might have lost their IDs in a sweep. And so that's also such a challenge, is that people who have had access to their IDs before, they lost them, and now we have to try and provide them again. One of the promising practices, again, that I want to highlight here too is the gate funds for people who are leaving incarceration, which is just a little bit of money. I think it was $200. Yeah, $200 to help people transition, so it can help buy a new set of clothes, help people be able to get something to eat, not be such an immediate burden on family or friends. And so those sorts of things are important for people as well. So just wanted to highlight that and hold that up as a really important uh, practice as well that the county is doing. And then back over to you, Heather, for probation and parole.
Thank you so much. We're really grateful. Thank you to the Hawaii Paroling Authority for participating. In addition to the judiciary, it really helps us get that information. And again, this is a living document, so as things change or if there's gaps, we want to hear from you. And I think that one, as you'll see when you saw when Dan showed you the whole continuum, one of the big pieces is how do we help people not go back into facility when they're on probation or parole, and spend a lot of time fleshing out what are the resources in community to help support folks. And as you see here, one of the most promising practices is the peer mentorship programs. As you know, there's now a forensic peer specialist that's recognized within the state for people that have a history with the system. And many of us know that when somebody has walked that walk, they can walk alongside other folks. And I think Going Home Hawaii is, and many of you on here, is a perfect example of uplifting those peer programs. There was a lot of discussion about the how does someone get revoked or go back inside from parole or probation, and how can we as community continue to build the resources to build that strength, and also housing being a very major issue, especially for our folks that have a history of sex offense. And knowing that if somebody's housed, we're more able to wrap around services and keep them hopefully out of incarceration. So gets back to some of the resource gaps that we've already talked about, and then getting also that piece of, well, what is the, as Dan wrote here, what is the therapeutic response for folks in substance use? Many of us believe that substance use is a reoccurring condition and that relapse is part of that condition. And so again, how do we address that from a health perspective, potentially instead of reincarceration? So Dan, I know we're short on time, so I won't wax poetic about harm reduction and around substance use. So I'm gonna give it back to you to highlight our lessons learned.
Great. Yeah. I mean, the things that we've learned are the things that you already know, right? It's so important to come together across these silos and to be able to actually work together to understand from all of our different angles what the challenges are and how we can do it. We also really want to highlight and pull out the value of lived experience and the diverse stakeholder input. Those things go hand in hand. So many people there were now working for an agency, and they used to be, they had previous incarceration experience, and people shared those stories there at the same time, which I think was incredibly moving because it shows what can happen when we're able to really support people and help them through some of the most challenging moments in their life. And this really gave us a strong foundation to improve on the opportunities created by the new Medicaid and HRSA policy changes, which is, I think, what oh, no, we're not going to go into that yet, but we're going to talk about that in 1 second. So Heather, do you want to share next steps, and then we'll talk about what those policy changes are that create the foundation for the future? Oh, you're muted.
Yeah, sorry. So we used Mentimeter. It's a real-time prioritization software that allows people to vote and prioritize, and for the group to see that real time. And so this comes from the prioritization that the folks did in the sessions. And it's really helpful that it seems to also lay out to many of the committees that the consortium already has. So again, surprise, surprise, I'm looking to expand housing and also mental health services, particularly the crisis centers. Continue to support, as I talked about, peer mentorship. Many of you know, in fact, I see several of you that are on the peer task force with me, that there is a legislatively mandated peer task force that's going to be coming out with recommendations that will support this effort. Well, we haven't talked a lot about data. Almost everything we have talked about needs data and needs data sharing in order to be person-centered, right? And follow that person wherever they're going and what their needs are. We know the consortium did high fuse, but there's also other opportunities to link and seek data from community, from healthcare partners, and within DCR. And again, tomorrow is our legislative session opening. So how do we use this report? And in fact, you better believe that I'll have a copy of this report when I go meet with the Big Island senators and representatives tomorrow to say this was in your backyard. This is what the community say they're needing. And then, how are you going to support these recommendations? And we haven't talked a lot about detox, but detox came up a lot, I believe. Dan, if I remember, there's no detox vacation for substance use on the Kona side, and there's only for men a brand new one, which is exciting, but nothing for women on the Hilo side. So how do we not just expand kind of what I call treatment on demand, but also get the detoxification services so that people can access other levels of care? And Dan, take us home with what I actually think that you do best, which is helping us translate some policy and get into how we can then uplift these moving into 2025.
Right. Great. Yeah. Happy to do that. So you all have heard me rant about the Medicaid 1115 waiver for a long time. And so the Medicaid is a state-federal partnership. Each state puts together their own Medicaid plan, and they can ask the federal government to waive certain components of the Medicaid program in order to better meet the goals of the state itself. So one of the things that Hawaii asked the federal government to waive is something called the inmate of a public institution exclusion. What that does is the moment someone's booked into jail, you lose access to all your Medicaid services. That means that the state ends up having to pay for services inside of the jail out of its own pocket rather than partner with federal dollars in order to improve services. And it also decreases the ability to have continuity of care because, if these systems are operating with different funding sources, it becomes really, really challenging to accomplish that. So there are quite a few things that are included in the Medicaid 1115 waiver, but some of the important things that I want to highlight is that the state asked for in-reach case management services, medications for opioid use disorder, office visits while in correctional facilities, behavioral health visits, 30 days of medications upon release, durable medical equipment. They asked for so many different components from the federal government, and they asked to start offering those services 90 days before release, and the federal government last week approved it. So what that means now is that we have the opportunity to be a part of shaping what this is going to look like on the other side. So the state has to put together an implementation plan for this, and then they have to actually implement that policy. And like I said, right now, the state is paying for a lot of these services out of its own pocket. So what Medicaid moving inside of the jail means is now federal dollars are going to be offsetting those state dollars. As a part of this waiver, the state has to take every single one of those offset state dollars and reinvest it into programs to divert people away from the justice system in order to expand services for people with substance use disorders. So this is a huge opportunity for us to shape what implementation looks like, but also what the reinvestment component of this looks like. So stay tuned to this. This is so exciting. I'm like totally thrilled about it. Also want to highlight, and this is another thing that has changed since we got together on this, is that there's a statutory change as a part of the Consolidated Appropriations Act that mandates screening and diagnosis for Medicaid-eligible juveniles. So that means that young people, Medicaid-eligible people up to the age of 18, or if they're aged out, foster youth up to the age of 26, to be receiving screening and diagnosis benefits 30 days before release and 30 days of targeted case management before and after release. That is the law of the land right now. I don't know that anyone's necessarily kicking it off very well, but this is a mandatory benefit right now for Medicaid and CHIP eligible juveniles. And then finally, the last thing I want to highlight is that HRSA, which is the Health Resources Services Administration, this is the federal agency that oversees how federally qualified health centers operate. So on Hawaii Island, it's the Hawaii Island Community Health Center is the major FQHC operating there. HRSA released a PIN, which is Policy Information Notice, that says that Now, federally qualified health centers are allowed to change their scope, which means that they can now go inside of jails 90 days before release and offer services in jails and prisons 90 days before release to individuals who are incarcerated. So that means that federally qualified health centers can receive their enhanced reimbursement rate and also legal protections to offer services inside of the jail above and beyond the services that are already offered. That's amazing because, like I said, Hawaii Island Community Health Center already offers these services. There already these are probably already the patients of the Hawaii Island Community Health Center in the community. And so this is just a new opportunity to be able to reach in. That, of course, would rely on an FQHC being interested in taking part in this and then going through the scope change process. And so there's still a lot of advocacy and work and talking to our partners on this to happen. But now the federal limitation that existed is out of the way. And this was something that my nonprofit was started back in 2005 to work on. And this just became the policy after Thanksgiving of this year. So, it takes 20 years for it to happen, but it happened. And so I'm really excited about what this could mean. So that's our presentation. I hope that got you excited to look